Welcome to this section. I will be discussing the topic Rhesus Isoimmunization. I'm Dr. Adeojo Idowu, a senior lecturer at the Department of Obstetrics and Gynecology, Ekiti State University and Teaching Hospital. At the end of this discussion, you should be able to define some relevant terms, understand the etiopathogenesis of Rhesus Isoimmunization, the pathophysiology, epidemiology, prevention, management, and prognosis. There are certain terms that are peculiar to the subject of Rhesus Isoimmunization. The first one is Rh factor, also referred to as a Rhd antigen. These are inherited proteins found on the surface of red blood cells. The gene responsible for this inheritance is located on the short arm of chromosome 1. Isoimmunization. Isoimmunization is defined as the development of antibodies against the antigens of another individual of the same species. And when we combine isoimmunization and Rhesus isoimmunization, Rh immunization, it is the development of antibodies by the mother, who is an individual, against the Rh antigen present on the red blood cell of the fetus of that same species. We also like to define erythroblastosis fetalis. This is also referred to as the hemolytic disease of the newborn, HDTN. And it is actually hemolytic anemia with characteristic blast, immature red blood cells on the blood film. Hydrus fetalis. What is hydrus fetalis? Hydrus fetalis is defined as abnormal accumulation of fluid in two or more fetal compartments, including ascites, pleural effusion, pericardial effusion, scalp, and skin edema. The etiopathogenesis of Rhesus isoimmunization. The human population is divided by the two major blood groups that we have. We have the ABO blood group and the Rh Rhesus blood group system. The ABO blood group system is divided into the A blood group, the AB blood group, the B blood group, and O blood group, as we know very well. The second blood group system is the Rh, or otherwise called Rhesus blood group system. Again, the Rh blood group system divides the population into two. We have Rh positive, those who have the Rh antigen on the surface of their red blood cell, and Rh negative, those on whose red blood cells Rh antigen are absent. If we combine 1 and 2 above, that is the ABO blood group system and the Rhesus blood group system, then we'll be able to divide the entire population into the major 8 groups. We have the O negative, those people who have O negative blood, those with A negative, B negative, and AB negative. We also have some subsets with O positive, A positive, B positive, and AB positive. Now, coming down to the Rh factor, there are 49 Rh antigens on the surface of RBCs. The 5 most important of these antigens are the antigen D, C, small letter C, capital letter C, small letter C, capital letter E, and small letter E. The most common and antigenic in the pathogenesis of Rhesus isoimmunization is the Rd antigen. That is Rhd antigen, Rh with capital letter D. Now, there are other atypical antigens which are also Rh antigens that are with the potential to cause severe isoimmunization. which are the C, the capital letter E, and the KEL antigens. The rest of the RH antigen, the Duffy, KID, M, and S antigen, they rarely cause significant problem in human. Now let us look at the scenario of the different RH blood group system. Now, if a mother who does not have rhesus antigen on the surface of the red blood cell, that one is described as a RH negative mother. And father that does not have it is referred to as RH negative father. And on the same vein, mother who has RH antigen on the surface of the red blood cell is described as a RH positive mother, and the father who has it is described as a RH positive father. Now, let us look at the different scenario that we may have. If a R rhesus negative mother marries a rhesus negative father, then the fetus or the fetuses they will give birth to will have no problem because the blood type are the same, RH negative mother, RH negative father. If the mother is RH positive, that means she has RH antigen on the surface of red blood cell, and the father is RH negative. Again, the fetuses will have no problem. Now, if the mother is RH negative and the father is RH positive, this time around the mother does not have the antigen on the surface of the red blood cell, but the father has. Then, if the fetus carried by the mother is RH negative, there will not be any problem. The last scenario is if the mother is RH negative and the father is RH positive. The first fetus that has RH positive can sensitize the mother, but that fetus will not develop any problem, no Rhesus Isoimmunization. However, the mother is already sensitized. Any subsequent RH positive fetus carried by this mother may develop hemolytic disease of the newborn of varying severity. This is otherwise referred to as a Rhesus erythroblastosis fetalis. The severity of this Rhesus Isoimmunization, the effect of the Rhesus Isoimmunization may vary from unaffected neonate, that is, the neonate may not be affected. The neonate may come with mild anemia, mild jaundice, severe jaundice, and to the extent of having hydrous fetalis or severe jaundice with brain damage, what we refer to as a kernicterus. Now let us look at what happens if a mother, RH negative mother, marries a RH positive father. Now the father that is positive can either be heterozygous for Rhesus D antigen, or can be homozygous. If the father is heterozygous, 50% of the fetus will be Rhesus positive and 50% will be Rhesus negative. However, if the father is RHD homozygous, in 100% of cases, the fetus will come out positive. Now, let us look at a scenario where the mother that is RH negative carries a fetus for the first time that is RH positive. The mother may become sensitized if significant number of red blood cells cross to from the mother to the fetus through the placenta by some event that leads to breach in the placenta membrane. And in this, we'll be talking about fetal maternal hemorrhage. That means the mother receives blood from the fetus. And usually throughout pregnancy, red blood cell can cross from the mother, from the fetus to the mother, but usually they are not enough to cause any significant problem. However, if the volume of the fetal-maternal hemorrhage is significant enough, it can lead to sensitization of the mother. The volume of the fetal-maternal hemorrhage that is necessary to sensitize the mother may be as small as less than 1 ml, while in some women, larger volume of blood may not even cause any sensitization. Now, usually, anytime there is a problem with the placenta, there is an issue that leads to a breach in the placental membrane, then more blood will flow from the fetus to the mother. And there are some events that we describe as a sensitizing event. That means during the sensitizing event, significant volume of blood may cross from the fetus to the mother. And if the fetus that has Rh positive antigen, that is, there's antigen in the fetus, cross into the mother, then the mother can become sensitized. Now, let us look at some of these events. There are some of these events that will expose the fetal red blood cells to the mother. One, if we have abortion that is less than 12 weeks with excessive blood loss. If the abortion occurs at less than 12 weeks and the blood loss is not excessive, there may not be sensitization. But if there is excessive blood loss, even if the abortion occurs less than 12 weeks gestation, then the mother may develop sensitization. Any abortion that occurs and the gestational age is greater than 12 weeks, irrespective of the amount of blood loss, the mother may be sensitized. Others include antepartum hemorrhage that can be caused by placental abruption, placenta previa, vasa previa, etc. We also have external cephalic version, which is a potential sensitizing event. Invasive procedures like amniocentesis, chordosynthesis, fetal scalp sampling, all these can also lead to sensitization in the mother. Trauma to the abdomen that is significant enough to cause breach in the placenta can lead to fetal-maternal hemorrhage. Fetal-maternal hemorrhage can also occur in ectopic pregnancy, molar pregnancy, and also even during delivery of the placenta at normal delivery. Now, there are some non-fetal exposure to Rh positive blood. The mother is Rh negative, but there are certain situations that is not because of the fetus. The one we have discussed above were caused by the presence of the fetus. But there are non-fetal exposure to Rh positive blood. For instance, if the mother receives Rh positive blood, then the mother can become sensitized. During bone marrow transplantation, the mother can also become sensitized. And if we have needle injury, when significant volume of Rh positive fetal red cell crosses into the circulation of the mother that is previously unsensitized, the reticuloendothelial system of the mother will respond by producing IgM antibodies. The IgM antibodies has high molecular weight and they cannot cross the placenta to the fetus. So the first Rh positive fetus that this mother carries will be unaffected. However, during this period, if there is significant fetal-maternal hemorrhage, the mother can become sensitized, such that the next time she's pregnant with Rh positive fetus, if the Rh antigen crosses from the fetus to the mother, the B lymphocytes in the mother will respond to the presence, because the mother is already sensitized, the sensitized B lymphocyte will respond by producing IgG. This time around, it is IgG, Rhesus immunoglobulin G antibody, that will be produced. The Rhesus immunoglobulin antibody has low molecular weight and can easily cross into the placenta. And if it crosses into the placenta into the fetus, and since the fetus is Rhesus positive, that means the fetus has Rhesus positive antigen on the surface of the red blood cell. The IgG antibody will set a stage for the destruction of the fetal red blood cells. And destruction of the fetal red blood cell will initiate the hemolytic problems, complications that this fetus will develop. The rapid breakdown of the red blood cells in the fetus will lead to fetal anemia. And when the fetal anemia is severe, this leads to congestive heart failure in the fetus. And the congestive heart failure, when it becomes pronounced, the fetus will begin to develop hydrous fetalis. That is presence of extracellular fluid in more than 2 sites in the body of the fetus as a result of the congestive cardiac failure and venous engorgement. The fetus begins to push out fluid into the extracellular space. Other complications that can occur as a result of this hemolytic destruction of the Rhesus positive fetal cells include polyhydramnios, placenta edema, intrauterine fetal death. Definitely when the anemia becomes pronounced, the fetus may not be able to stand the continuous hypoxia, and the fetus may succumb. Scab and skin edema. When the fetus is eventually born alive, that means all these can occur intrauterine. If the fetus is successfully born alive, there could also be some varying degree of complications like anemia at birth, neonatal anemia, mild to severe neonatal jaundice, and in severe cases, we have kernicterus, that is neurological damage in the brain of the fetus. Now, there are some factors that will determine the severity of the sensitization. Like I've said before, the fetus, there could be some level of fetal maternal hemorrhage, that the blood can be as low as less than 1 ml, and the mother is sensitized. And occasionally there could be large volume of fetal maternal hemorrhage, and the mother is still not sensitized. So there are factors that determine whether the mother is going to be sensitized. And these factors include the type of the rhesus factor. Like I've discussed earlier, the D antigen is the most immunogenic. So if the D antigen is present, the likelihood of sensitization is very high. Other antigens like the capital C, small letter C, capital letter E, and small letter E, they are less immunogenic. And if this one crosses into the mother may not be sensitized. Now, number 2 is ABO incompatibility. I mentioned before that there is ABO blood group system. And under this ABO blood group system, we can have ABO incompatibility. And it is being found that the ABO incompatibility actually protects against Rhesus Isoimmunization, because the ABO blood incompatibility will have removed some of the red blood cells that are Rhesus positive. And if they are removed, a significant amount is removed, the RH sensitization by the RH antigen may not occur in the mother. And we also look at the volume of the fetal maternal hemorrhage. If the volume of the hemorrhage is small, the mother may not be sensitized. And epidemiologically, black race has also been found to protect against Rhesus Isoimmunization. Now we're going to quickly talk about the epidemiology. Now, epidemiology. The whites have more incidence of Rhesus negative patient. About approximately 15 to 20% of white patients are Rhesus negative, as opposed to 5 to 10% in black. So that means the blood type, the Rh negative blood type that does not have the Rhesus antigen is commoner among the white than the black. And in all patients that are Rh negative, it is just about 17% of them that when they are exposed to fetal Rh positive blood cells that develop antibody. Now, we are going to quickly go into prevention in this case because this is one scenario where the saying that prevention is better and cheaper than cure is very, very apt. And we look at it that way because prevention of Rhesus Isoimmunization is cheaper and better. Now, how do we go about this primary prevention of isoimmunization? All women within reproductive age group should have their blood group and Rh status determined. That means we should be able to know whether a woman is Rhesus negative or Rhesus positive. And the women who are Rhesus negative, when they get married, the male partner Rhesus D status should also be determined. Because if we know in advance, then we begin to mount preventive measures. Now, all women who are Rhesus negative and married with a Rhesus positive partner, anytime they present in the antenatal clinic for antenatal care, at the first booking clinic, they should have indirect comb test, ICT, indirect comb test. The indirect comb test, under the indirect comb test, since the mother does not have the antigen on the cell membrane, red blood cell membrane, then a sample obtained from animal with Rhesus antibody is incubated with the mother's blood. That is why it is indirect, because the mother does not have it. And if the Rhesus antibody, Rhesus antigen, if the Rhesus antigen gets into the mother, it attaches to the surface of the red blood cells, such that when there is a prepared blood that has, a prepared serum with Rh antibody is mixed with this blood of the mother that already has acquired the antigen, there will be agglutination. What I'm trying to say is that ab initio, the mother does not have Rhesus antigen. The red blood cells is now persuaded to take up a Rhesus antigen supplied from the outside. And the blood sample is now mixed with another blood with Rhesus antibody, and there will be agglutination as shown above. And if the indirect comb test done is negative, if it is negative, then it is repeated every 4 weeks. And if they remain negative at gestational age of 28 to 32 weeks, then the mother should be given Rhesus D immunoglobulin. That is the common one around us is Rogam. We give them Rogam at between 28 to 32 weeks. The Rogam will prevent the development, any small fetal maternal hemorrhage that occurs, even in pregnancy. The Rogam will mop them up such that the mother will not be able to recognize, the mother will not become sensitized. It will be the red blood cell that will be present that can get to the mother will be below the critical level at which sensitization can occur. Now, the Rogam, and if the woman does not deliver after 40 weeks, her delivery, another Rogam should also be given to the mother at the dose of 300 micrograms. Should be given to the mother. And this one will eliminate any potential for sensitization. And if the ICT at this stage is positive, that means the mother is already sensitized by the events that we have mentioned above earlier in this presentation. If the ICT is already positive, then the administration of the Rhesus D immunoglobulin is no longer necessary. So at that stage, it is no longer necessary. Now, like I've explained before, how the Rhesus immunization works by mopping up Rhesus positive fetal red blood cells that enter the maternal circulation early enough before the mother is able to mount an alloimmune process. Now, when we are not sure, because the level, the Rogam that is given, the Rhesus D immunoglobulin Rogam that is given to the mother, usually if you give a dose of 300 micrograms, the 300 microgram will be enough to mop up the fetal maternal hemorrhage. However, if we suspect large volume of fetal maternal hemorrhage, then we should add additional 10 microgram of Rogam to every 0.5 ml of Rhesus fetal maternal hemorrhage detected by the Clara-Bettke cell test. This test is done. This is acid-based elution test to denature the blood cells of the mother. And because the fetal red blood cell can withstand stress, so even when acid or base is added to the red blood cell of the mother will become denatured and they will appear like ghost cells. Whereas the fetal red blood cell will not be denatured because it is strong, it contains fetal hemoglobin with high resistance to denaturation. And it will be visible on the slide as a rose pink in color. And we can count the number of the fetal red blood cell in the maternal blood circulation to determine the volume of the fetal maternal hemorrhage. Now, for those who have abortion in less than 20 weeks, like we have said before, abortion less than 20 weeks with a high volume or excessive hemorrhage, it can be a sensitizing event. And for those who belong to this category and they are Rhesus negative, that means everybody who has abortion, every woman that has abortion should have their blood group determined. If the woman does not know it before, we should endeavor to check the blood group of the mother. And if the mother is Rhesus negative, the mother should receive 50 micrograms of Rogam if the pregnancy is below 12 weeks. However, if the pregnancy is above 12 weeks, a higher dose of 150 micrograms should be used. Now, how do we manage when the woman is already sensitized? Like I've said before, a woman that is already sensitized, the use of Rogam may not offer any advantage. So when the woman is already sensitized, then we will now begin to talk about the management of isoimmunized patient, the woman that is already sensitized. And the goal of management in women that already sensitized is to ensure that the fetus is delivered close to maturity before the onset of the complications. I've mentioned some of these complications before, earlier in this presentation. So some of these complications that may occur, because some of those complications, they are usually very, very severe. They may be severe in the fetus. So we need to actually manage the woman and ensure that the fetus is delivered early, such that before the onset of the complication. And we also must be ready to prevent and manage early neonatal complication of Rhesus Isoimmunization. Now, what are these intrauterine complications that we are trying to avoid? We want to quickly ensure that the fetus is optimized and delivered in very safe and healthy condition. One is fetal anemia. I've mentioned that before, fetal anemia. This is as a result of the hemolytic process that occur and which is associated with Rhesus positive red blood cells that is already sensed and exposed to IgG immunoglobulins. And this fetal anemia can lead to congestive heart failure, and the congestive heart failure can also lead to hydrous fetalis and intrauterine fetal death. The neonatal complications include what we classify as hemolytic disease of the newborn, characterized by neonatal anemia, neonatal hyperbilirubinemia, that means the neonatal jaundice. And if the jaundice is severe enough and the bilirubin crosses the blood-brain barrier, it damages the brain and leads to kernicterus. And we can also have early neonatal death. Now, for women that are isoimmunized, they are to be managed, they are supposed to be managed, and we should endeavor that they are managed in a dedicated fetal-maternal unit for comprehensive fetal surveillance. This is very important because a high level of expertise is required to manage isoimmunized women who is carrying Rhesus positive baby. Now, there should be close monitoring of the antibody titer every week, and Doppler ultrasonography should also be conducted to be able to measure the mid-cerebral artery, the peak systolic velocity of mid-cerebral artery. The measurement of this is very important. So the antibody, initially we begin to monitor the antibody titer in the maternal serum. If the antibody is higher than 1 in 128, then there is indication for the measurement of the mid-cerebral artery peak systolic volume. Now, the Doppler ultrasound scanning is performed to measure, and this one is done to actually ensure, to be able to detect the evidence of hydrous fetalis, and so that we can quickly initiate the management. There are monographs for the measurement of a mid-cerebral artery peak systolic volume according to the multiple of media at different gestational age. And the significant value is if we have value that is equal or above 1.5 MOM, that is a multiple of media. And anytime the value it is higher than this is considered to be associated with significant fetal anemia. And if the value is less than 1.5, multiple of media will continue to repeat it after 1 week. If it reached 1.5, then we repeat it after a week. If it remains at that level, or higher, this is an indication for us to now transfuse, because the fetus is now suffering from significant anemia. Then we should do chondrosynthesis and intrauterine blood transfusion. However, before I progress in this discussion, I want us to also let us know that before 95 and before the measurement of the mean cerebral artery peak systolic volume became widely available, then we were monitoring the isoimmunized pregnancies with serial amniocentesis to detect the level of bilirubin. And the amniotic fluid is subjected to spectrophotometry to determine the optical density at 450 mils. And the value gotten was usually plotted on Lilly's and Freder's graph. This graph has 3 zones, and when we get to the severe zone, that is zone 3, we know that there is an indication for us to intervene. However, in the recent management of isoimmunized women, the serial immunocytosis has now been given up in favor of measurement of mean cerebral artery peak systolic volume, because serial amniocentesis require an invasive procedure. And I also mentioned earlier that it also has the potential, that is, amniocentesis has the potential of increasing the antibody titer or by causing fetal-maternal hemorrhage. This is a typical Lilly's graph with zone 1, zone 2, and zone 3, depending on the level of the value of the amniotic fluid bilirubin gotten from the optical density, from spectrophotometry at optical density of 450 mils. And if it is severe enough, then if it gets to the range of zone 3, then that means the isoimmunization is severe. There will be fetal intervention. Now, if the mid cerebral artery peak systolic volume is greater than 1.5 multiple of median, then we have to be sure that the hematocrit is not low, because that is showing that that fetus may be suffering from significant anemia. And if the fetus has attained maturity, then the fetus will be delivered. But if the fetus is still far away from maturity, the fetus has not achieved the age of maturity, then there is an indication for that fetus to be transfused in the intrauterine environment. So intrauterine blood transfusion has the potential of saving the fetus. And the first thing to do is to first of all determine the PCV, the packed cell volume, the hematocrit of the fetal blood gotten from chondrosynthesis. And if the packed cell volume is less than 35% in the early mid-trimester or 45% thereafter, it may be an indication for us to intervene when the PCV is low. And the desired PCV that is targeted at the early gestation, early mid-trimester, is between 35 and 45, whereas in the later trimester, we'll be targeting between 45 and 55%. Then the PCV we desire will determine the volume of blood to be transfused. And the volume of blood to be transfused is actually calculated from the formula, the desired PCV minus what we now observe, the fetal PCV, divided by the donor PCV, and minus the sour PCV multiplied by the fetal placenta blood. The blood to be transfused should meet certain criteria for safety. One, the blood should be Rhesus negative. It should be irradiated. The genotype of that blood should be genotype AA, and the blood should be HIV, hepatitis, and cytomegalovirus negative. And this is the kind of blood that is proper. And that blood should also be properly cross-matched to ensure that there are no other Rh antigens, like I've mentioned it before. Others like the C, capital letter C, E, capital letter E, He, and Duffy. They should be screened to make sure that we exclude all the other atypical Rhesus antigen. And the blood can be delivered into the fetus through the umbilical vein. And it can also be delivered into the fetus through the peritoneal cavity. Usually the peritoneal cavity is favored when the gestational age is early or the access to umbilical cord is difficult, like when the placenta is lying posteriorly. In anteriorly lying placenta, it is possible to access the umbilical vein easily. And the blood should also be transfused at no more than 10 minutes in 1 minute. That means the blood to be delivered to the fetus should not be more than 10 minutes per minute. And before we begin to transfuse, 1 ml of the umbilical vein blood is aspirated to determine the PCV. And we also do this after the procedure. Cardiotocography should also be performed for at least 1 hour after the procedure to exclude any fetal heart rate deceleration. And what about postpartum? We're able to the transfusion is done intrauterine and the fetus is optimized and the fetus is delivered when matured. And after the delivery, the surveillance for the baby now that is born should continue because there are some postpartum complications that can occur as a result of Rhesus Isoimmunization. That at delivery, the cord blood sample of that fetus should be collected from the maternal side without contamination with maternal blood. That means when the baby is separated from the mother, the placenta is separated from the side of the cord that is close to the placenta, we obtain blood samples from that cord or the maternal side. And we obtain the blood sample to determine the following. The PCV, the baseline PCV of the neonate. We also do direct comb test. For the mother, I mentioned that we do indirect comb test. But in the fetus, we're going to do direct comb test because the fetus already is assumed to have, the fetus already has RHD negative antigen. So we're going to do direct comb test for the fetus. And we also determine the tutu and conjugated bilirubin, the baseline. Because these are some of the problems that the fetus can have. And we have to monitor the fetus serially to be careful that the fetus does not develop severe anemia and jaundice. And if it required, intensive prophylactic phototherapy and postnatal blood exchange transfusion may be necessary to save the life of the baby. The prognosis for Rhesus Isoimmunization is good, particularly if it is detected early and managed in expert hands. The prognosis will be good. However, if not properly managed, the fetal prognosis is bad. Now, we have talked about isoimmunization that is due to RD antigen, that is Rhesus D antigen. The D antigen is usually the commonest, and I've mentioned before, the most immunogenic. But there are other antigens that are there that are also related. They can cause isoimmunization, and they can also cause some problem in the fetus. So it is good for us to have a high index of suspicion for other rhesus antigens. And how do we know? How are we able to get this? Let us suspect other rhesus antigens if there are history of hydrus fetalis, neonatal jaundice, and exchange blood transfusion. And on typing the blood of the mother is either Rh positive. That means the mother is not Rh negative. Rh positive mother that is having hydrus fetalis, neonatal jaundice, or the baby has had a chain blood transfusion in the past. And if you when you do, for some of them, for the mother who is rhesus negative, rhesus D negative, and they have negative ICT, that means there is no antibody. They don't have RD antibodies. The ICT is negative, despite the fact that they are rhesus D positive or rhesus D negative. This category of women with positive rhesus D negative with negative ICT, indirect home test, and they are having recurrent intrauterine fetal death, neonatal jaundice, blood transfusion, hydrus fetalis, then we should suspect other rhesus antigen. The rhesus antigen, some of them I've mentioned them before, the capital letter C, small letter C, E. You also have the KEL and the Duffy antigens. All these are also other atypical rhesus antigen that may be found on the red blood, on the surface of the red blood cell. And these should also be managed. Essentially, the management of these other rhesus antigens are essentially the same. Monitoring with antibody titer and the mean cerebral artery peak systolic volume. The only difference is that the antibody titer is not very informative. So that means the management also depends on monitoring of the mean cerebral artery peak systolic volume. I would like to conclude this session by saying that the diagnosis of rhesus D antigen is a universal component of antenatal care. And this has enabled the escalation of primary prophylactic prevention for Rh as immunization and then we now have the widespread availability of human-derived RD immunoglobulin program. This has reduced significantly the incidence of rhesus isoimmunization in rhesus negative mothers with rhesus positive fetuses. The availability of amniocentesis and recently Doppler ultrasound scanning to measure mid-cerebral artery peak systolic volume, cardiotocography, and skill for intrauterine blood transfusion have greatly improved the survival of rhesus positive fetuses in isoimmunized rhesus negative mothers. Thank you.